Well, we hope you had a good lunch.
Yeah.
And we'll introduce this panel. I guess I would say that you will never have an opportunity to ask questions of an expert panel as good as this one is for the rest of your life. So I hope you've got good questions. I asked your coordinators to have them ready. I have a set of questions too that came from American University site reviews and some questions that we've had here. And so this is a good opportunity for you to ask questions to improve your drug court operations and your outcomes. So we'll start by asking Carson to introduce himself and pass this down the line.
Hi, I'm Carson Fox, the Chief Executive Officer of NABCP.
Carolyn Harden, Chief of Training and Research with NABCP.
Dennis Riley, Director of Treatment Court Operations at the Center for Court Innovation.
Greg Pinsky, District Judge in Great Falls and Veterans Treatment Court, Drug Treatment Court.
I'm Mary Jane Knisley, and I'm a District Court Judge here in Yellowstone County, and I currently have a felony impaired driving court and a Veterans Treatment Court.
Hi, I'm Valerie Moore from Portland, Oregon. I opened and ran our treatment agency for 16 years for the Multnomah County Drug Court, second one in the nation. And I have been working out in the field providing technical assistance as a consultant through BJA and its justice program through American University.
Hi, I'm Tracy Velasquez, former Montana resident, and now with American University. I'm the Associate Director of the Justice Programs Office there.
Hi, I'm Phil Breitenbuscher. I'm the Director of the National Family Drug Court Training and Technical Assistance Program.
Okay, thank you. And I don't know if I sent an email out to other experts that were outside of Montana, and if you're out there and would like to come up, we'll find you a chair. So the first question is a question that I think the Bureau of Justice Assistance is continually asking and concerned about, especially in rural drug courts. And I think BJA is concerned about it because when they fund downtown Manhattan and Washington, D.C. and San Francisco and L.A. and all these great big cities, they get their numbers, easily. And rural drug courts have a little bit more of a problem generating the referrals to the numbers that get projected in the grant applications and stuff. So the question is, and I think this is a question that the site reviewers from AU have continually seen as a problem, and that's in rural areas, how do you get your numbers up? Are there any particular strategies that you have run across that help to generate a caseload for high-risk, high-need people?
I have a couple things that I've found in the field in some jurisdictions that, on the ground they say the capacity is 30 and yet they have 3 or 4 people in the program. One is to consider the probation officer, if you do have one in your drug court team, referring people who are not doing well before they have a probation violation, and working mechanisms to bring that into the team. The other thing you can do, obviously, well, not obviously, is hear from the treatment providers. They know who they're working with, who is doing well. And, so expand your thinking about who you can bring in besides the front-end people who are the rest.
I'll comment on that, Jeff. Really think about having a universal screening process where you have some agreements with your prosecutor as to who would be prima facie legally eligible. We've been working on universal screening approaches in New York State for a number of years, and really putting it in the hands of the arraignment clerk to really just have a kind of a bench card, for lack of a better term, to see who would be potentially eligible as they're coming in for arraignment. And then that case immediately goes over to the prosecutor in the drug court to determine legal eligibility. And that can be a very, very quick process. Now, if that person's not eligible, clearly they have to go back to another docket. But at least there's a way for it to get from arraignment directly to the person who is trained and who can make the legal eligibility determination very quickly, sometimes within 24 hours. So build that legal eligibility criteria, somehow get them directly from arraignment to that prosecuting attorney who can make that decision, and it really speeds up the process and creates kind of a universal net.
I just wanted to mention teleservices also. In our state, teleservices have turned out to be a really good thing. We have a pilot project with teleservices where some of the more rural drug courts are able to have people dial into treatment using the Polycom apps off of their smartphones or off of tablets that have been provided. The tribe has a lot of tablets and things like that. And then the Department of Corrections has just redone their regions, and so they've been able to make referrals to the more rural drug courts using teleservices for both compliance checks and treatment.
Anybody out here got a question? Come on. Yes.
I was just going to add one thing, which is that if the part of the problem with referrals is the people who make referrals don't know or don't understand the drug court, or maybe a little dubious about its benefit to their client. If it's, for instance, a defense attorney really trying to do more community outreach, outreach to the people who could make referrals to make sure they understand the benefits of people going to the drug court or family or juvenile drug court.
You know, one of the things that I've done, and this is just advice to my fellow judges who are out there and prosecutors and defense lawyers, we've agreed in order to screen people as efficiently as possible and to get them eligible offenders into the drug court or the vet court as quickly as possible, the first thing that we've done is we send all of those cases to me as the presiding judge. So at that point, I'm able to, use a firm judicial hand in moving those cases along. We've agreed to prioritize those cases. So for instance, if someone is identified, the county attorney has offered a plea agreement, I'll set it for a change of plea hearing on the next possible day. And I'll do a sentencing on that day so we can get them into drug court right then. I think some of the things that happen as judges is we get sort of pigeonholed into our usual calendar, where we're going to wait to have an arraignment, and then we're all busy, we've got this crowded docket, we'll get to the change of plea hearing in 2 months, and then we'll set the sentencing a month down, and by that point, we've got somebody who needs to get in treatment, and 6 or 7 months have passed. And so it's taken a commitment on the part of myself, on the part of the prosecutor, on the part of the public defender, to identify these cases, transfer them to me so that I can get them set as quickly as possible, and then I've made the commitment to myself to set those cases as an absolute priority, because as we all know from the research, the sooner we can get someone in a treatment program, the better, or the more likely that a positive outcome will result.
Thanks, Judge. Switching to a different subject, and I think, Carson, you're probably going to cover this in your constitutional issues workshop, but when does a drug court participant have the right to a fair hearing? And isn't there some case law around that? And I guess, is it federal case law or is it state case law? Or can somebody respond to that?
Does anybody else want this one? Okay. If y'all are interested, y'all can come to the session tonight. There's a growing body of case law, and it is all state case law. There are no federal cases right now about due process. And the question, of course, is that fundamentally is when there's a liberty interest at stake, that we know people are entitled to due process, but then what process is due? The case law is mixed. It's actually, there's some really interesting cases. There was a fascinating, there's been fascinating cases all over the country. It's hard to give you a firm set answer because even though there are several cases, the cases really now are only in a few states. So we don't have enough cases nationwide where I could tell you that there is this broad trend across the country. And there, like I said, haven't been any federal cases. What we recommend people do is the most conservative course, because there's very few judges I know of that want to be taken up on review and have their case be the test case. When we teach it, and y'all will hear me teach it this afternoon, those of you who attend, if someone has a liberty interest at stake, for example, if they're going to be terminated from your drug court and that termination means that they're going to be going to prison, or likely to be going to prison, it's basically another step on the road there. It's difficult to disagree that a liberty interest would be at stake. If any of us were going in front of a judge for a hearing, and that hearing would result would result potentially in us going to prison, then a liberty interest is at stake. So then if due process kicks in, what elements of due process are necessary? The case law there tends to equate that drug court revocation with probation revocation. So you have a Gagnon versus Scarpelli, the lawyers in the room are talking about, and you have the elements that are available there. Then you get into the area where you have sanctions, intermediate sanctions that could be jail sanctions. And so then there's a question, what about intermediate sanctions? There's even less case law there, and it's also mixed, and we'll talk a little bit more about that this afternoon. And that's a longer conversation, so I'll just use that as a teaser for those of you who are interested in coming. But I'll tell you that since there's less case law, it's even less clear cut. But again, if there's going to be a hearing and y'all are sending me to jail, I don't think anybody in this room disagrees that if I'm going to jail for 2 or 3 or 4 days, that that's not a liberty interest. If any of us were going to jail for 2 or 3 or 4 days, we would think it was a liberty interest. So then the question is, if then that's a liberty interest, so what processes do? And we'll talk about that some this afternoon.
Anybody else want to respond to that?
I just wanted to mention too that in multi-judge districts, it's a lot easier to fulfill some of the suggested due process requirements as far as also offering your participant a different judge than the treatment court judge for that termination hearing. Typically, they choose the treatment court judge anyway, but my understanding is that's what you're supposed to do, and it is easier in a multi-judge district, but I just want everybody to know we're happy to hold those hearings for you, the other judges, if you need somebody as an impartial judge.
Thank you. All right. Is there a question? Otherwise, I'll keep going. Yeah.
Jeff, I have a question. Are there guidelines somewhere about how many days is an appropriate jail sanction?
Guidelines on appropriate days for jail sanctions. I know there's research around that because it's in the standards. Do you want to, Carolyn, do you want to respond?
I'm also teaching on incidents and sanctions, I think, after lunch, and we'll talk about that. I'm apparently very busy today, Jeff. So yes, there is. And basically what the research says is that less is more. That when you get to a period of incarceration, I believe, not without looking at the slides, kind of seeing them in my head, 6 days or more, you really have negative effects. And I'll tell you as a prosecutor from a very conservative jurisdiction in South Carolina, I talked to y'all yesterday about that, when I first saw the research, it struck me. I was struck by it. But when you look at the research, small bursts of incarceration motivate behavior. If you're looking at longer than that, you're really looking at punishing someone, you're not as much looking at motivating their behavior. So we have to ask ourselves, are we there to motivate this person, or are we there to punish them? And those are two different tracks. And we'll talk about that a lot in incentives and sanctions when we talk about incarceration and its role in motivating behavior.
Anybody else? What do they call that? Flash incarceration? Something like that. Yeah.
You know, one thing I'll add, these due process concerns can take on a real-life example. I just did a site visit to a veterans court 2 weeks ago that imposed an automatic jail sanction upon a positive test. And that raises a whole bunch of issues, but from a due process standpoint, they had a situation where an individual tested positive, and so they immediately put the individual in jail. The individual denied use, they didn't stay the jail sanction, and then the confirmation test came back negative. So you have a situation where somebody's wrongfully jailed. And that's a huge, I mean, look, everybody in this room recognizes what a huge due process issue that is. And so those are the types of situations that these due process issues can arise in.
Well, that is a good segue into this next issue, and it's entitled Therapeutic Responses. A significant issue is the overuse of jail. And what is your perspective on the use of jail? When should it be used? When should sanctions be used? When should progressive therapeutic responses be used? Should jail be used for a positive UA? Is this a brain disease or bad behavior?
Sooner or later. So, clinical. This is drug treatment court. People come into our programs, they have substance use, they have mental health issues. We have to distinguish, is this a clinical issue? And if it is a clinical issue, then we should have a therapeutic adjustment. If our job, as Carson said earlier, is all punishment, then we don't even need to do this. We need to do business as usual like we used to, and then we can all sit back and say, what a great job we did in incarcerating people, because that has worked out so well. But when we really look at what the issue is, let's take, for example, you have someone who comes into your program and they use when they first come in. There's a bunch of questions that need to be asked, and it is incumbent upon us to do our jobs and ask questions. Where were you? Who were you with? What was going on? Where is the client at that moment when they come in your program? Is this a proximal behavior or distal behavior? Because if I am a high need, meaning moderate to severe, based on DSM-5, and I am standing in you, I've been in your program all of 25, 30 days, what do folks do when they use drugs? They use. So I'm going to use drugs probably when I first come in your program. Someone needs to have a discussion at that point to say, where were you? Who were you with? Because if I was with my using buddy, this guy right here, Dennis, and you're always with Dennis, do you always drink when you're with Dennis? Yep. Do you always get high when you're with Dennis? Yep. What's the proximal behavior that I actually have control over? Anybody know? Dennis. One of the reasons in treatment, and it's not just a cliche, you need to change people, places, and things. It's not cliche, people. It's a real reality. I have proximal control over hanging out with Dennis, but I may not yet have any skills, any tools yet to stop, to say no to that alcohol, to say no to that drug. I haven't got there yet. My mind hasn't even got to a place where I can even accept all the tools that treatment is giving me to have the ability to say no to that. So when it comes to your question is, where are they? What phase are they in? Is this a proximal behavior or a distal behavior? And we have to stop looking at just the drug test. Because guess what? Drug courts are not about sobriety. They're about recovery. Everybody needs to get that in your mind. We are pushing recovery, not sobriety. I can be sober all day and not have made any other significant changes that lead to behavior modification. So here's what you don't want to do. Let's not get them sober so that now that I'm sober, I know how to better rob your house because I can see what's going on. I have to address all of the behaviors that a person presents with. So the drug test is one tool that you have in drug court. But what is the client doing? Are they clinically stable? Can I articulate to you what I've learned in treatment? Can I demonstrate that I actually know how to put these skills that treatment are giving me into practice? And if I can't demonstrate that, that might be the real issue that you need to focus on. And the sanction that you give me need to help me build skills to make lasting change. So when I leave your program, I actually have the skill set to not come back in your program. So that I actually 5, 6 years from now, I might have a relapse, but I also ought to have tools that say, don't go down this road. Here's what I need to do. I need to take a moment back. I need to go back to my meetings. I need to go back to doing what I learned how to do to stay sober. So, I'm not sure if I answered your question, but you do know this is my pet peeve, right? So, we have to begin to look at the whole person. Because a client can be standing before you and really passing all your drug tests, but have made no significant changes. So therefore, recovery for them may not be attainable in a long-term way because they haven't done the behavior modification. I've got to be honest. I've got to make life changes. I've got to find some new friends besides Dennis, if that's my using buddy. I've got to talk about that. I've also got to figure out, and here's the other thing for you as practitioners, we've got to quit thinking that people know how to make new friends. Some folks don't. We've got to give them skill-building tools to practice that. Think about, for some of the folks coming in your program, if they started out in this lifestyle years back, they probably didn't make the right friends in middle school, high school. They were the bad kid at the table. If you're asking that question, who's the bad kid? Nobody was the bad kid at my table. So, when we're looking at that, we have to help them because now you're talking about going to do something scary. I don't know about for some of you all, but there are some people going to a new town, going to a new school. That's very scary. Now we're saying to our participants, all those people you hanged around with that were using drugs, all those places that you went to that are familiar, that are safe, you now can't go to those places. We've got to help them, and drug court is the ground for them to practice. So they should be practicing how to do that. They should be telling you what that feels like, what you experience, so that they can get used to those new skills that they need to develop.
I'm sorry. I just had two things that I can. Is that working? Can y'all hear me? Is that better? Okay, so first thing, I love her. Second thing, y'all probably don't know, her middle name is Subtlety. There are some cases, and I'll review those briefly this afternoon too, where appellate courts have looked at some drug courts that they viewed as being excessively punitive, and the appellate courts have not been friendly in their opinions. So I will tell you that, especially when you have we've seen appellate courts around the country reviewing some excessive, for example, sanctions, and they basically called into question, can you really be a therapeutic court if this is a sanction? If this person has spent this much time, for example, behind bars, how can you call yourself a therapeutic court? And there have been some very, very harsh appellate decisions that I've seen in the last couple of years.
Boy, I'm glad that Carson spoke after Carolyn. I don't. She's hard act to follow. Just a couple things that I've seen. Always treatment providers. Therapeutic responses first. You know, if you don't have the result of the UA yet, you certainly know that there's some changes in behavior. They're missing groups. They're not participating. They're nodding off. They're excusing. They're whatever. Something has changed. It's really up to you to take that information, make a new treatment plan, make a new therapeutic response, get in alignment with your participants, and then speak up at the staffings. Too often I've seen things going on and there are minutes spent trying to figure out what's happening with this guy. And treatment doesn't speak up. So that's a big pet peeve of mine. They see you and the probation officer or the case manager. There may be some course correction that will save a whole bunch of time in jail. And for heaven's sakes, don't endanger what's already been built for them. If they've started a new job, don't endanger that job. And by the way, this is the Best Practice Standards, Volume 1, page 26G. So use these best practice standards. They're there for a reason for you to refer to.
Let's go a little further with this issue. Let's assume now that drug use for our participant, Joe, is proximal. And that he has been in drug court for 3 months, 4 months. He's been clean and in treatment and doing well for 60 days. And all of a sudden we get a positive drug test. At what point do we start to think about adding a sanction to a therapeutic response?
Well, here's my answer to that. I may give you a sanction and a therapeutic response. Because your clinical issues are clinical, that's responding to your clinical need. There is still, because if you're taking in high-risk population, they have a criminal element that we also want to address that behavior. So it is not uncommon that when you give out that someone is going to get a therapeutic adjustment, treatment is going to work with you to address that. But the court still needs to address that other behavior and not just be like, well, we know you're high need, that's okay. No, they're high risk. We want to address that criminal behavior, whatever that is. So if they were in the wrong place, they may get a sanction about that. Something to do with, if it's people, I may give them an essay, or I need you to identify how you're going to pick some new friends. What's going to be your process for staying away from dentists? There's a lot of tools out there for courts to use. One is that your clients are doing manualized treatment. They have homework. They have different things that are exercise, skill building. There is Change Companies. There is Hazelden. There's all these workbooks that you can give them that give them some directed activities, exercises to do between this court visit and the next court visit. And here's something courts need to do. When you give somebody a sanction, the next week when they come to court, they ought to talk about that sanction and what they got out of it, what they learned from it, and how they're going to use these new tools they got to revise from it. And then it ain't a sanction the next week to ask them, how's those tools still working? Because what happens is, I've got my answer for you this week, but the next time I see you, you don't ask me about that again. I never have to continue to practice. It's all about having them practice. And so you can give a therapeutic adjustment as well as a sanction. You can also give an incentive in that. You could do all three. I'm so glad you showed up. I'm glad you were honest about that. Now, let me tell you, treatment is going to work with you to address that. But because you violated this program rule, we're going to give you this project to do, and we want you to talk about it when you come to court on next week. I'm giving you everything.
I think this goes along the same lines as what others have said, but I think as you're looking at your participants, whether they be in family drug court or adult drug court, understand the difference between a lapse and a relapse. And we've talked about recovery versus sobriety, but we try to say remission and then moving towards recovery. Samson's now got 4 domains of what recovery is. Recovery is not treatment. Treatment provides you tools so that you can begin on the road to recovery. But the 4 domains that Samson's now come out with in recovery are community, home, health, and purpose. And as you think about your clients and where are they at when they come into your programs, those 4 domains are all a mess. Certainly in the family drug court world, their home is a disaster, it's chaotic, their health is in poor shape, as is many times their children, both their physical health and mental health. Their community, their people, places, and things is a disaster, is chaotic, are people we're going to move them away from, and they have no purpose. Their purpose is drug-seeking behavior. How am I going to get that next fix? When they wake up in the morning, they're thinking those things. And as you move them into recovery, you want to be looking at those 4 domains. Is their health in good shape? Have they begun going back to the dentist? Are they taking care of their kids' health? You can go through those 4 domains and really see where a person is at in terms of their recovery versus just have they tested negative for all drugs in the last 6 months. Really looking at those 4 domains. But going back to lapse versus relapse and how you might respond differently, you have a participant in the family drug court world, most likely would be a mom. And if she's been doing really well, she's 3, 4, 5, 6 months into the program. I told this story in one of my sessions yesterday, but it's a holiday, and her kids are in foster care. Because she's burned every bridge, she can't talk to her family doesn't want her over for Halloween or Thanksgiving or Christmas or Easter. And this is a real case that I saw. It was on Easter just a few months ago, and when I was visiting in court. And so the only person that reached out to her on Easter was her old boyfriend, who would continue to use. And she went to that place, that person, and she did use. And but at 3 in the morning, she wakes up. She's feeling horrible about her use. She was on the phone with her sponsor by the time by 6 o'clock in the morning. She'd have left a voicemail for her case manager. She'd already, by the time she got to court a week later, she'd already gone to 4 or 5 meetings. She learned tools of how she had to get back away from that person, get back on her journey of taking care of herself and her recovery tools. And so that was a quick lapse, but she was able to demonstrate how she could get back in. You respond differently to that versus that mom who does the same thing with boyfriend, but instead of feeling guilty at 3 in the morning, she disappears for 2 weeks, and she starts selling her kids' toys so that she can continue to get loaded. That response will be completely different from that full-blown relapse versus a lapse. So.
And we need to change our responses too. I mean, I would encourage you to resist the urge to immediately be kind of deficit focused. It's been 3 months that you've been clean. What were you doing during those 3 months that was working for you? Start that way as opposed to jumping on the dirty urine as the first thing that you say and do. We need to change our responses too.
Okay, that kind of fits into the next issue, and this was one that AU identified. There's a lack of focus on maintaining participants in drug court. Many programs are too quick to terminate. We know that graduates do much better than early leavers, so when is enough enough? In other words, when have we gotten to the point where we really need to terminate somebody because drug court isn't working for this person?
Well, I think probably each participant is different, but once you've gone through trying to incentivize even the smallest productivity, trying to make sure that your therapeutic responses and your continuum of care has been adjusted, when you look at what's going to happen if they're terminated and you discuss that, you try other alternatives, or you look at what that's going to look like for that client, you certainly don't want to be terminating clients in front of the arena of all the other clients and have them getting less than they would have gotten to begin with and things like that. I think you really have to look at each client and try to do every single thing that you can using the best practices and making sure that you've done what you need to do. Or like Carolyn said, I mean, you might as well have just terminated them and put them in jail to begin with. So looking if they've had traumas, looking if things have changed, really trying to give them credit and motivate them as they even make small changes, and using your sanction grid equally and comparing them to the other folks a little bit, but really looking at what got them there individually to begin with.
And I just add the court's, traditional role has been protection of public safety, right? So especially if you're beginning to be concerned, maybe if they're in a DUI court and you're worried they're going to go out and kill themselves or somebody else, or engage in criminogenic behavior, they're going to go rob somebody's house. I mean, anything that could potentially, make you think that the public safety is more at risk if they stay in the program than if they go back to a traditional sentence is something to think about.
Anybody out there got a question?
I have a question going back to Dennis being back. What happens when your dentist is a very young female's mother? Father is disabled in a nursing home, and she's got mom, and mom is a raging alcoholic, doesn't get in trouble for it, but mom is her, she's 20. Mom is very important to her life, and mom kind of just doesn't act like there's any reason. I mean, there's no problem. So I get mom out of the picture without coughing her.
Well, we don't want to catch a case. True story. I had a client when I did supervision who came in our program who always would get back in trouble every time because of her family. And what the issue was that it was always a dirty drug test for marijuana. So sort of like what Dennis said. He said, what do you do well when you don't get in trouble? And she talked about it. So then we went back to, she gave all these scenarios. Well, I'm with my family, we do this. And then I get popped. And this happens, and I'm with my family, and this happens, and we get popped. And so we wrote it out, and we put it on a big piece of paper in my office. And I said, circle the one consistent thing. She was like, it's my family. She's like, I love my family. I said, I know. I said, so let's talk about what can you do in this scenario that still allows you to have a relationship with your family because you want to keep that, but don't want to end up back in jail and with me. So how do we do that? Then we had to peel back that onion and begin to look at, well, where did this happen? She said, family dinner. And here's what she told me. From as early as she could remember, age 6 or 7, at dinner, they would pass a joint around and everybody took a hit. So that was the norm at family dinner. Now, I don't know where you guys are from, but you don't come in somebody and say, oh, your mom and daddy, that's terrible. Your parents are awful. I would have lost her. I said, okay. So now, every time you do that, how much time do you spend in jail? And we mapped out her jail time. We then mapped out what have you lost as a result of that you would like to do. And so she started talking about that. I said, now, where do y'all always use it? She was like, at the house around dinner. She said, always generally around dinner. She still has a relationship with her family, but not at their house at dinner. She meets her parents and she meets her family out at places. And she did that for 2 years until she had about a comfortable level that she would go and she never went alone. She always took somebody else who did not use. So when it came down to doing that, she left. But we had to peel back the onion to get her to figure out what is it that you want. Because you can't go at it at the mama and say, well, you don't. Because let me tell you something. All of you probably got Thanksgiving holidays that come up. You got that relative that you know when they show up, it's going downhill. You have a plan. You have a plan for when you're leaving. Our clients don't have a plan because nobody's ever taught them a plan. They've never had an opportunity to identify, what have I lost as a result of this? Is there something else that I want? I'm doing a session here called Understanding Risk. What we do is we do a risk assessment, but we don't teach our clients to understand what risk means and how they are high risk. And until we help them understand what that means and what their risky behavior has cost them, has led them to, and they have to come to that identification of it, you don't have an opportunity to do what you're talking about. Because I'm not going to leave my mama. Because I love my mama. But I now have to figure out, is mama worth dying for? Or can I have a relationship with mother that is still, that I can talk with her, but I can also protect and take care of myself? Many of our participants don't know what that protection looks like. And then it becomes a cultural issue also. For some folks, it's culturally that I'm supposed to be with family. I'm supposed to do that. Then we also have to help them figure out, how do you maintain that relationship without the expense of your freedom? And it's a conversation. For some folks, they'll be able to get there. For some folks, they will not. But we also have to begin to help them. And as Phil pointed out, when we talk about recovery, community is important. And if your court doesn't have community included, and community may not look like your courthouse, it's outside. Because if I can connect them with their family, and sometimes many of our clients don't have a traditional family like we do. They have a community of existing, of family members, of elders, of cousins, of relatives, of folks that they call auntie that ain't really their auntie based on how we, or you might believe auntie, but may be a surrogate that can assist them with that change. And if we haven't connected them to that, we lose that opportunity.
Just a couple points to add on to what Carolyn said. So we are seeing, even in the family drug court world, and maybe even in your adult drug courts, younger populations coming into care. I was just in Iowa and observed a court in Polk County where there wasn't one person in the courtroom over the age of 22. So we really encourage that court to look at the adolescent treatment research. It's really been expanding lately, and SAMHSA has a resource on adolescent treatment for 18 to 22-year-olds. So if your population, you're dealing with a 20-year-old there, she really has an adolescent brain still, and her treatment should look different than your treatment of your 28 to 34-year-old participants. And the same thing, another TRI has a good resource on adolescent treatment, and there's also, you can take a look at a developmental approach to juvenile justice, which also is calling for how to apply justice to that mixed age group, 16 to 24-year-olds. So those things you may want to think, what's the court's response to this young person? What is the treatment response to this young person? Because it's going to involve family most of the time.
Thanks, both of you, for that. It almost sounds, Carolyn, like some of those issues are what clients are ambivalent about for getting well, and a motivational interviewing strategy to get over that ambivalence. Aftercare and recovery support services. We know that alcohol and drug dependence is a chronic brain disease. We can no longer treat it as an acute health problem. What is the responsibility of the drug court for the long term, that is, after drug court?
Well, I just sat in on a great workshop by Jeff and Mona Summer, and where they presented their recovery maintenance check-in, and makes a lot of sense. They're looking at long-term, a very easy way to check in with people, up to 90 days, and perhaps, the research has shown, if you can stay in touch with them for 5 years, you're going to have a lot better outcomes once they leave the court. And they're not suggesting, I believe, that the court keeps a person coming back for 5 years, but that somebody, this is a very structured conversation based on motivational interviewing. I've also seen when we were running our treatment agency that it was an open-ended, come back whenever you want. And some of the graduates did come back. They came back for individual counseling with their primary counselor. They came back to a group. So building that opportunity to come back and stay in touch right at the beginning, adding to their recovery plan, knowing that the doors are open, that the phone will be picked up, and I think it's really, really important.
I'll add just a couple of things. I know that, especially in the mental health world, the use of peer support specialists in looking at recovery, as you know, we spent a pleasant hour talking about Medicaid this morning and what's available and what's not, and really shifting. We need to see a shift in the public health world towards seeing recovery as a long-term process. That is going to take resources, and it's not just going to happen. I would add that I think that there is only so much that 5 years from now, is it the court's responsibility? We can discuss that, but I think what is the court's responsibility is creating the opportunities for people to build those relationships, like Carolyn talked about, where there's available support for them that can continue past the term of the drug court. So if your person is, for instance, if you've mandated them to go to an NA or an AA, but they really don't feel like they're making connections there that are going to last for whatever reason, say, okay, well, what is going to work for you? Is there a church that you might like to go to, or is there another way that you can build pro-social relationships that can help you in your recovery after you're done with the drug court? I think that is a responsibility of the treatment court.
I was just going to add that my understanding is that the announcement for implementation and enhancement grants in the next go-around is probably going to add some money, but also require some very specific recovery management strategies to be included, like alcohol and drug-free housing, like peer support groups, etc. And I'm wondering what other kinds of strategies like that are you aware of that have been effective after drug court?
So two things. If your court has tunnel vision, then you will close the door for our participants. The door should never be closed. They should have an opportunity. But your program should be built so there is a bridge that clients walk across. And the walk across of the bridge is, while they're going through our program, we introduce them to community supports. Your program should be introducing clients to those natural supports that exist in the community. If I am 100% dependent upon you and don't know how to get those other supports that I have exist in my community, know where to go, whether it's a local church, whatever it is that is a part of my recovery programming, then I will have some of those problems. So when we look at long-term continuing care, in my utopia world, we all will recognize that drug court is a great intersection between public health and public safety. And when we look at the public health issues, we don't cut people off for other things. Many of you go to the dentist and lie every time. Have you been flossing? Yeah. He can tell. He doesn't say, don't come back to me. He still serves you. When our clients have issues, the door should still be open. And if we do our good job of helping them to understand, there's this program, there's that program, these are other things that exist in the community. This church has a program. They also offer these type of services at the health department. There is peer recovery, there's coaching programs. What you're going to have to do is really get out in your community and understand what's available and what exists, and then bring those to the table so that the clients are introduced to them. Jacksonville, Florida does something very unique in their court. When they have staffing, they open their jury room and they have local community agencies. It could be a church, it could be the health department, but somebody comes in from the community and says, this is what we offer. These are the times that we are open. We have 24-hour services. Our services cost X, Y, and Z. If there's a cost, they're free. There's a number of churches who come in and talk about, we offer counseling, we offer this. It's non-religious based. You can come and get access to it. They actually have the hospitals come in and talk about where they have free clinics. They have the attorneys come in and talk about where they have free clinics. And guess what they do? This is really phenomenal. They give them credit for that if they show up as if they went to a meeting, because they're getting information about what exists in their community. One of the other courts in Missouri, Judge Blankenship, he has in his courtroom a board, and it's called the Community Board. It's just a list of things, and he requires, when they get into phase 3, they have to agree to do, they have to pick something from the board that they are involved in that's a part of the community. And every week when they come to court, they have to tell him what they got out of the program. Was it beneficial? How did it help you with your recovery? Do you see it? If it didn't help, how did it help you with your family? Did it do something to inspire you? They have a whole set of questions, and every week somebody has to talk about it. You know what has happened in their program when they did it was because they had a high number of folks who would leave and use. Ever since they started doing it, they did a 6-month study to look at those folks who graduated. They went from 2 graduates every graduation having a relapse to 0. To 0. Because folks had something else that they felt connected to. They now moved it back and start getting people engaged in those community resources. Now you know what's interesting is that they have clients coming in and adding stuff to the board because they now have made it their job to find out what exists in the community. They've now got them out looking for things to get involved in their community and bringing it back. The judge now says that the alumni folks come in and say, let me educate you about a couple of new things that are happening in the community that are beneficial to their participants. Who would have thought such a thing could happen? But it has, because they've opened the door. If you have tunnel vision and you think only you at the courthouse can help the folks, you missed the big piece of recovery, which is community, and the other piece is giving folks a purpose and letting them find what that purpose is.
I also want to add something, because when we talk about operationalizing continuing care for drug courts, there's a lot of responsibility on the coordinators, on the treatment providers. In Massachusetts, they're actually adding peer navigators to their staffing sessions. So they determine that they are a core member of their staffing team, and as recovery-oriented systems of care are moving into a reimbursable state, you're going to be able to find people who can play that role of a peer navigator for recovery services and actually sit as an equal member at that staffing table.
Yeah, Sacramento County uses what they call resource specialist. So at the beginning around phase 3, the parent is paired up with a resource specialist, and that person helps them connect to the community of resource centers and how to get back up to TANF, and if you're out of compliance, and how to get connected with other community agencies. That's one model. Alumni groups is another. In Riverside County, they would begin in phase 3 ordering parents to attend alumni groups as they were getting or starting phase 4, a 4-phase program. In the 4th phase, they would order them to attend alumni in replacement of a meeting. So then their alumni always had a lot of people in it. And then they would stick with it afterwards. The recovery checkups, what's the court's responsibility? I would say the court's responsibility is when you're contracting with a treatment agency that you require the treatment agency to do long-term recovery checkups. An excellent program, if you want to look into it, is out of Connecticut. Phil Valentine ran the program for many, many years. He got lots of awards and recognition for doing this. I think they had thousands and thousands of clients that they would be checking up on. And I like Phil Valentine for a lot of reasons. One is he likes to train on the use of language, and this is off topic, but it's a funny story. He had talked about, he never understood substance abuse, never understood that term. Because a long-time cocaine user, he'd say, I never abused my cocaine. I kept it in a nice box, I protected it. There was no abusing that. I might have abused my dog sometimes, but I didn't abuse my cocaine. But I used it quite a bit, so I like Phil Valentine for that reason. So those are a couple ideas for you.
As a non-clinician, the concept of continuing care is a difficult one. And you learn the lesson the most tragic, hard way possible. And I had a veteran in my veterans court who went through the court without one issue for 18 months and relapsed and died 6 weeks after he finished the program. And that caused a lot of evaluation. And Dr. David Mealy, who some of you may have heard at some of the national conferences, did sort of a treatment autopsy on this veteran that we lost, and looked hard at his continuum of care. And the way that he described continuing care to me was as follows, and it really made sense to me then. He said, it's like when you go into a grocery store and you ask a clerk where the baking soda is, and the clerk says it's over there. Okay. You go into another store and you ask the clerk where the baking soda is, and they say, well, it's someplace over between aisles 1 and 10. Okay. You go into other stores where you say to the clerk, where's the baking soda? And the clerk says, let me show you. And they take you there. And so putting together a continuing care plan that establishes exactly where the participants are going to go, what resources they have available, when they're going to do it, having that first appointment made for them when they graduate, giving them a laminated card that tells them who they can call, where they're going, what groups, their support groups they're going to continue to attend. Those are the sort of things that can be done to not just say to somebody, it's over there, but to actually take them and link them to the resources that they need in order to stabilize their recovery.
Thanks, Judge. I would encourage, and I did in the last session, and I have for a long time, that there's a treatment plan that gets developed by the treatment program and the treatment counselor, and it's pretty much driven by the treatment counselor. It's signed off on by the client, but it's a treatment plan. But there's also a self-directed long-term recovery management plan. And that's developed by the participant with a framework, from us, and it's their plan, because they fill it out. We look at it, we might make a few suggestions, but it's their plan, and it's their plan that they're going to have to use 2, 3, 4 years after they leave us. And to dovetail with what the judge said is, if you can start them on that plan, their plan, in the last phase of drug court and get them used to what they need to do to keep that plan in place, even after they leave us, then we've accomplished a lot that will help prevent them from relapse and reoffense. And if you are interested in what that policy might look like and what that plan might look like, I'd be glad to give you an example. Let's move on to a really difficult area. Synthetic drugs are a real growing problem. I don't think we even have an idea about how bad this problem is because we're not, in a position where we're detecting it. Given that your analysis may or may not identify synthetic drug use, what other ways are there for dealing with this issue in drug court?
Well, I was actually hoping to learn something at our webinar, which we're doing right now, which people can download next week on this subject. But I would just add that I went to a really interesting, so by the way, you can down the flash drives, are just, don't want to bring these home. There's flash drives out there that have all of our webinars, except obviously the one that's going on right now in synthetic drugs, so grab a flash drive. But I went to a program that was sponsored by John Jay College and some others about synthetic drugs a couple of months ago. And it was really interesting because they talked about sort of like the different reasons that people use synthetic drugs. And that's part of the challenge, right, is that some people use them as sort of as a primary drug of choice. Some people use it because it's not detectable and they're on drug court. And it's going to be difficult for us to stay ahead of synthetic drugs because they keep changing. They keep changing the formula, so they're hard to identify, they're hard to catch. But I think that it's going to be a growing problem, and what I learned at the conference too is it really drove home how dangerous that they can be for the people who are using them. I mean, basically what they're doing is, a lot of these are made overseas. They take a bunch of weeds, they spray a bunch of chemicals on them. The weeds on this side have 3 times as much chemicals as on this side. So this person's going to end up convulsing in the street, and this person's going to, maybe have no effect at all. So, I think it is going to be a growing problem. And one of the things they emphasize is really to understand, what is going on in this person's life that they're using these drugs as a way to help try and identify, do they have additional stressors that, for instance, like you said with that mom, who's like, I don't want to test positive, but I am having the worst day of my life. And how do you address that versus someone who maybe is trying to beat the system? So,
one other thing that I would highly recommend, if you don't know it, you have a DEA. You have a DEA, Drug Enforcement Agency, which is local. You should reach out to your regional or local DEA, and they can tell you, because they track. Each one of them has offices where they track what the synthetic drug use is, where they are. So if you really want to know what is happening in your community or in your state, what is happening with especially synthetic drugs, reach out to your local drug enforcement agency. They have people on staff whose job is to go out and do just that education component. They can tell you what they are working on. They can tell you what they're tracking and what they see. As it relates to what's coming into where you are. That's real beneficial to know because they are kind of keep their pulse on what's the new synthetic, what's the different changes, and especially what's happening. Also, I would encourage you to go to ndcrc.org, which is the online virtual library for all things drug court, ndcrc.org. There is on there, and it was probably sent out about a month ago, sponsored through the National Institute of Drug Abuse, with a couple of the other treatment aid providers, put together a thing for folks on synthetic drugs to kind of show you trends and tracking and what's going on. So it's a cool little document that I would suggest that each drug court have in your resources. So it gives you some information, and I truly suggest that you contact your local DEA. And also, many of your local DEAs are working with your police departments, your narcotics divisions, and their task force. So if you have one of those, you may also want them to come in and educate you about what they are actually saying local. Because there are, across this country, several of them that are working together, especially as it works to synthetic drugs.
This is where you have to rely on your treatment providers, your probation officers. You have to correlate abnormal behavior and with the drug tests that you're able to use. And you can literally, in addition to bleeding yourself dry, just pull your hair out trying to solve what substance somebody might be on. And, you know, Redwood has some 130 panel spice-related synthetic cannabis test that they're supposedly constantly tweaking. It costs you $40. And if you did that on every participant multiple times a week, it wouldn't take long before your minuscule state budget is totally depleted. And so you've really got to pay attention to behavior. You've got to rely on your treatment providers. And that's the only way that you're truly going to be able to manage the synthetic use effectively.
Thank you, Judge. Any questions from out there? Okay. We hear a lot about trauma-informed drug courts. I think there are a lot of us that really don't know what that is. I think we've had a workshop or two here on trauma-informed drug courts. But I know during the site reviews at AU that there's been some criticism that some of our drug courts are not trauma-informed. How does that translate for all of us to understand what that means and what we can do about it?
Well, again, it's looking at the underlying issues, and we know that a majority of our folks are coming into our drug courts with co-occurring disorders, either mental illness and substance abuse, physical health issues, and it's now we're becoming more enlightened that there are some underlying trauma issues that may have happened a long time ago. And it, often, I think to some of the law enforcement folks, it might sound like an excuse, but it's not an excuse. So we encourage people to, money is always an issue, but we encourage people to look at the Central website and look at the evidence-based practices and promising practices that are out there right now. Seeking Safety, I'm not tooting anybody's horn, but Seeking Safety is not expensive. You can customize it and still have fidelity to the model. Started out as a very good program for women, and I believe that there's now some other curricular workbooks for men. And that's what I would say about it, that people take some time, learn some more issues about it. How does trauma show an effect when somebody is in drug court, especially in veterans courts? We know that there's a lot of PTSD, TBIs, but that may also be true with people in your drug courts. I heard a great workshop when we were in Anaheim this year, given that talked about somebody who falls and hits their head actually has their brain bounces, so it hits the forehead and it hits the back of the head. Finding experts or doctors in your community that can come in and over a brown bag lunch give you a little mini workshop on trauma. What does it mean physiologically, neurosciences, maybe there's some clinical psychologists. So I would start getting some information and going to school, and then begin to systematically look at what are the available tools to help address the symptoms of trauma.
So, on addressing the trauma issue, one of the critical things that you should know, there is research studies that show 75% of the women who come through the criminal justice system have pre-existing trauma. The other issue that you need to also recognize is that people of color, so we have our Native Americans, our African Americans, are coming to your programs with historical trauma being a very real issue and coming in and trying to navigate the criminal justice system based on their historical issues with it. So when you have these things that are coming in, it is beyond being trauma informed. What we're hoping drug courts get to be is trauma responsive. And so that requires you to not just know trauma exists, it means that you've got to respond to trauma. That means that, well, not only is it okay for you to have a risk assessment, a substance use assessment, a mental health assessment, you got to have a trauma assessment. And you may not be doing your trauma assessment when they first walk in the door. We are also seeing that another bounding set of research says you probably shouldn't give a trauma assessment until 3 months in, when you've built a relationship with some of the folks that they don't think you're out to get them. They're more apt to answer your trauma response. The other thing that I want you to know that is on the horizon, and you'll be able to ask for in 2017. We've been pilot testing. We have a new trauma. We have a brain, your brain and trauma. So this really kind of walks you through what we now know on the science that shows here's a brain pre-trauma. Here's what the brain looks like based on having ongoing trauma or some of those effects. Even to the point where we can explain to you about some folks live in neighborhoods where trauma is an issue. I can tell you one of the best drug courts that have a great trauma responsive practice is in Chicago, where they are dealing with oftentimes day-to-day street shooting. Somebody is shot and killed before you even get the group. And they have responses. They have a whole plan, a program, and action of what they do that's being trauma responsive to the individuals who they're serving. So there is a number of things, and you will be able to, come January 1, request on-site training for us to come in and assist you with how do you become trauma responsive as opposed to just being trauma informed. Because it's okay to know, but more importantly, what you do is the next piece. And so there are different things that you can do. And I've been to a number of trainings where they tell you, well, in court, judge, you all shouldn't stand behind them. You shouldn't do certain things. Yeah, that's great, but we have some rules at the courthouse where the bailiff needs to be and what happens. And so we have to talk about beyond trying to make some things that way, there are other pieces that you can put into place that also show to the participants you understand what is going on with them and don't want to re-traumatize. Even to the point where when you look at the ACE study with some of our youth and young development, adult drug courts need to understand what that study says and shows, and especially because a number of your participants are coming in. Phone call I had yesterday from a court. Carolyn, what do? We have a juvenile, and he says he can't give. We have documentation from a doctor that says he can't give when people are looking at him. And I said, okay, and she kept talking. I said, can I stop you for a minute? The child was probably sexually molested at some point. She goes, yeah, how you know that? Well, he's having some difficulty giving. They've been doing this for a while. And we go through it. They were looking at, well, we don't want to take him in the program because he can't give. I said, so he would be better off in detention instead of you doing a blood test, instead of you doing something else. And you're telling me that his family says that they're willing to pay for him to get the service? First off, let's just stop there. He's got family that's willing to help. So we have some resources that he's bringing to the table. But that's really a trauma unresponsive court. So we really have to know what to do and how we can be open to what we can do even within our limitations of the court system.
Are you aware of screening or assessment instruments that are likely to be used by a drug court to identify trauma? Can you enumerate those? No?
I could do a follow-up. I know Miami does a trauma assessment on each person, and we actually did a little bit of coaching with one of the judges there because it was great. They went to training. They just said, we're going to implement trauma assessments for all clients right at the get-go. But then I went and observed the judge, and she says, you know, Mom, based on your trauma, you're gonna need this real high level of service. And the mom didn't want to. And this is open court. There's a galley of people in there. And she says, well, don't you want to talk about what happened to you while you were 5? When you were 5? And we were like, whoo. So we had a little conversation with the judge on that. That's trauma unresponsive. Yeah, that is trauma. A couple of resources we have. So one, we have a webinar on our website, which is cfusers.org. You can come and give me your card if you're interested in it. It's called Trauma Informed Courts. It's mainly directed to family drug courts, but probably could be applicable to others. We also have a trauma walkthrough checklist. So coming into your courthouse and then walking through how a client would. We have that available to you also. So one of those would be of interest to you.
There is, we have a tool called 6 Steps to Addressing Co-occurring Disorders. It's on our website, and you got it here. So in the back of that document is some assessment tools. You can also go to the Gain Center. They actually have a TOT coming up for training the trainer on their trauma course, and they have a list of resources. And there is a document that was done by Dr. Roger Peters called Screening and Assessment, and it's on the Gain Center website. And on that, in that document, there is a list of the trauma assessment tools. And also, isn't it the VA? I'm looking at Scott. What is it?
Yeah, if you go to the VA website, ptsd.va.gov, go to the professional section, you can get the PCL. The PCL is a trauma survey. It's a screen. It's a great screen. They have a PCL-C for civilians. They have an M for military. And they also have a new 5 that corresponds with the DSM-5. So there's lots of really cool assessments on there beyond trauma. But again, it's being trauma responsive. So these are instruments that you're going to use to be prepared that you might be putting triggers out there to trigger the client. So just be aware of...
Give us the URL again.
It's ptsd.va.gov, or if you just Google PTSD VA, you'll get the National Center for PTSD.
Okay, good, thanks.
I just wanted to add sort of a rural drug court. I mean, we were at a drug court here in Montana, and they were struggling because they're a small court, and there's only one treatment provider and one treatment session a week, and they had a woman there who we were concerned might have been a trauma victim. In fact, we're pretty sure she was in a room with a bunch of guys. And the response to the court was, well, we only have one treatment session a week because we're in a very small town in Montana. So this is not to say you might not have challenges as you try and think about, like, sort of walk through your whole process. Where might there be triggers for people? Where might it be difficult to do things? But I think there are a lot of, all the research definitely shows the relationship between the number of people who've experienced trauma who also have substance abuse disorders, which started as a coping mechanism. So it's something that you're going to see, whether it's historical, military, community or sexual abuse. All those things are going to be in your court. And the Flash Drives also have a webinar that it talks about drug courts and some simple things you might look at doing. It also talks a little bit more about just sort of what trauma is. So it's on our Flash Drives out there too.
We're going to run out of time. Go ahead. Oh, you can, Carson, always.
Obviously a lot of good information this afternoon. We're almost finished. There's one thing that I do want to finish up and maybe this is because I'm in Montana and I'm just a country boy. A lot of this sounds out of reach. A lot of this sounds difficult. But I will tell you it's not. I will tell you that I have been so inspired by the drug courts I've worked with in rural areas around the country. I will tell you that I worked very recently with another training and technical assistance provider, not NADCP, and I learned in working with a project on them, a big national project, that they were highlighting certain courts in the country, and they had among these courts one in a jurisdiction that's a city known all over the world, with resources that are beyond my imagination. And in the same project was a court with virtually no resources in a very rural area. And that rural court outshone the big court. It was amazing what they were able to do. You can do this. You really can. And I know that many of you are already doing these pieces, but I think that it's something that, I came from, we ran 2 drug courts. One of our drug courts was in a tiny little jurisdiction with no resources at all. And we had to figure out and do the best that we could. But I don't want you to think about this, because we've heard a lot of cities talk about it here today, like Chicago and San Francisco and Manhattan and places that are completely foreign to where I was raised and how I grew up and lived my life. But I will tell you, there are just as many courts in places that are rural and remote that are doing these same amazing interventions.
Thanks, Carson. I want to ask one more question of this panel, because it was an issue identified by American University, but I know it's been an issue at different times in Montana as well. And so it's the issue is a lack of team cohesion and role confusion. And I guess my question is, are there resources that you would recommend that would help with those kinds of team-related issues? Dennis?
Sure. I'm going to be doing a presentation at 3:30 talking about, if you don't have leadership, you don't have team, you don't get to the complex issues, right? So there's certainly some new presentations that are being developed. There's role descriptions that you can find. But whose responsibility is it to orient new team members? The Center for Coordination on the National Drug Court Online Learning System is developing new role-specific presentations. So it's going to have to be someone's responsibility. Team building is still something that's kind of at the core of trying to get a highly functional team. If you don't have a good team, and that means having interagency partners who are committed and also trained, so you have thoughtful assignment of that bailiff who very much cannot have received any training in trauma-informed systems and a therapeutic courtroom environment. So that's just kind of a touchstone maybe for a later session about how we want to be thoughtful about assignment and about orientation into team roles.
Yeah, the other thing that I've seen and helped some jurisdictions with around the nation is really clarifying the difference between your traditional roles and your roles and responsibilities within the drug court environment. And we all know they're not the same, but I have found it to be a great benefit when people actually can sit down together and examine them in writing and really write a new job description. And I don't mean just a little paragraph that goes in your grant application. Drill down to exactly, very specifically, what are the different things that you are charged with doing in the drug court team that you wouldn't be doing otherwise. The public defender comes to mind, and that's probably one of the clear, more clear things. But also, then take some time and look at your roles and responsibilities within the context, perhaps of a participant from day one. Who is involved with that participant, and at what point, and at what time? And if there is a lapse, or a relapse, or a missed group, or whatever, whose responsibility it is it to respond to that? And where is their crossover? Sometimes, so there's not role confusion, but there's role understanding and knowing the differences in the times where you really maybe blend your roles. Figuring out a way that you can have immediate responses and that everybody on the team knows who's to respond, and what's happened. I know I just worked with a group in a remote area in Southern California, and they all have iPads. And I said, iPad? But they use them right at the moment. If somebody's at somebody's house, if a PO goes or the case manager goes and they see something that's not good, they need to respond. Well, right then and there, they let the rest of the team know.
I've got two suggestions for you that are free, and in my estimation, a great way to build your team and establish a vision for your court. The first thing is to set aside time every month. We do it on the first Tuesday of the month. We have a brown bag lunch. We have our team come in. We don't talk about participants. We don't screen participants. All we do is talk about, it might be a presentation from someone on a treatment-related issue. It might be talking about how we're going to implement this new process of screening people. You're able to talk about those things. I mean, we all know that our time is very valuable. It's difficult to get through your staffing. You've got court. If you're like me, you've got 1,600 cases on your docket, and your time's valuable. But if you set aside that time for a brown bag lunch, you're going to be able to bring some focus to those things that you need to do for your court. The other thing that I would highly recommend that everybody does is have an annual planning retreat. So we schedule ours months in advance so that everybody can put it on their calendar. We go to an off-site facility. We fill the walls with all of those little big white pieces of poster paper. We write down our goals. We write down the things that we want to accomplish. It generates excitement. It builds the team together. And everybody's able to work toward a common goal and a common vision. And it gives you that opportunity to focus on the things that you've learned at conferences like this that you want to do for your court that you otherwise don't have time to talk about.